Welcome to the ultimate guide on how to become a doctor in Australia. In this video, we will take a deep dive into different Australian Medical Council exams, AMC 1, AMC 2, on how to prepare for them, what's the total cost, different types of visa that you need, how much does a doctor earn in Australia, what's the lifestyle like, what's the residency training structure like, and everything in between. My promise is that by the end of this video, you will become an expert in how to become a doctor in Australia. So today, I have a very special guest with me, and this is Dr. Rizwan Qureshi. Dr. Rizwan Qureshi currently is an emergency medicine consultant in Australia, and he has trained thousands of students on how to get into medicine in Australia.
Hi, I'm one of the consultants working here in emergency medicine in Sydney. I've been in Australia for about close to 18 years, Manik, and it's a pleasure to meet you finally.
And so, Dr. Qureshi, why AMC? Why become a doctor in Australia?
Oh, that's a long story, but I'll make it easy for you. They're both professional reasons and personal reasons, and I always believe that personal reason are more important, Manik, when it comes to making a decision about your overall professional growth. And the personal reasons might be related to your family ties. It might be related to your aspiration that, look, that doctor has gone and is doing very well in life. He's settled. He's got a good, nice family style. For me, it was a more like a scenic route, what I call it. So I went to the UK first, did the PLAB. After about 3 years in the UK, I was not getting many opportunities. The market was super saturated, which I think is currently happening as well. For me, the natural course of action was to go to Australia because they were doing a roadshow. So I came here, joined the emergency medicine training, and 18 years later, there's no looking back. I think for people right now, they're faced with these 3 exams or 3 big destinations, which is USMLE on the top. That's the favorite exam of all the people in India and Pakistan and even Bangladesh and Sri Lanka and some of the Middle Eastern countries. The next exam is UK. And finally, now AMC is coming as a big contender. And if you look at the personal factor which I was talking about, in Australia, the lifestyle is laid back. It's a very good combination of what I call the urban and the regional and the rural. So there are 3 tiers of lifestyle, and the facilities generally in all these areas are pretty much similar. Obviously, if you're living in an urban setting, it's more expensive. Regional is less expensive and rural is cheaper. So I think the lifestyle is definitely one big factor. Good weather, good nice scenery, places to hang out, and that makes it all worthwhile. The other reason is salary. So this is a big issue. When you compare the salary to the UK, it's definitely better. I would say at least 1.5 to almost 2 times better. If you plug in the lifestyle concept, the more regional and rural you go, the salary sort of increases. I was looking at figures a few weeks ago, Manik. I think it is still better than even in the US. If you compare to all the odds in terms of cost of living in Australia versus cost of living in the US, what you earn in Australia versus what you earn, the disposable income, which we call the saving income, is better here in Australia. It's pretty good. So these are the short-term sort of salary and the personal lifestyle. Plus, the other thing is that there's a lot of migration happening on Australia. Australia is inviting people from all sort of skilled industries in engineering, in computing, in IT sectors. So you'll find that Australia is not like what it was 10 years ago or 5 years ago. It's completely different. There's huge sort of numbers migrating from India. So there's a lot of local food and delicacy. So you don't feel completely left out, that you're down under. They call it down under, that you're completely lost touch with the world. So you feel at home. And finally, the long-term personal factor is that once you become a fellow, surgeon, physicians, your degree is world-class accepted. Similar to US and UK degrees, you can go and practice in your home country in India, in Pakistan, in Bangladesh, in Middle East. But you may have to take a Canada exam, and not in the US. I think US is pretty much keeping the borders closed from that point of view. Even in the UK. So it's pretty well-rounded approach. And now on an average, there's about 5.5 to 6,000 IMGs joining every year. And they're joining from all different levels. So there are junior doctors, which are at intern levels and RMO levels. There are middle grade doctors at senior RMO and registrar level. And then there's senior doctors at consultant level. It's a very good opportunity for everyone. And I don't think that many countries offer that sort of breadth of intake across the range of specialties and across the range of seniority. So I think from that point of view, it's now become somewhat a very favorable spot. And I think looking back, if I had to do the whole thing again, Manik, I would say that I would probably prefer Australia as number one destination for postgraduate medical education, training, and life generally.
Wow, I think that's a bold statement. But just asking in terms of like Australia, if you're comfortable asking this question, how much do you make if you're okay revealing the figures in terms of Australia? How's your lifestyle? Like how are you working? What's your work-life balance like?
Yeah, sure. So look, I work as a consultant emergency physician, and as a consultant, there are two types of job that you can do. You can be hired by the hospital in a permanent contract. So it's called a staff specialist contract. And then you can also do a long-term, you get hired by another hospital for 5-year contract. So I do 2 days, meaning part-time, as a staff specialist, and then 1 day as a locum kind of thing. So I work 3 days, and rest of my days are dedicated to my business, which is emergency focus. And I am very comfortable. I make between $350,000 to $450,000 with my part-time income. So I'm very happy with that. It's giving me good balance. But Manik, it's not about the salary. When you go to work, it is a breeze. Like I've worked in the UK. The number of patients that I see, the teams that I've got in terms of medical team, the nursing team, the resources are so good that I'm not overwhelmed. Like I don't feel that I need to work full V8 engine and try to sort everything out. So the patient safety, the amount of work that I'm doing with good quality care, which I want to provide, I'm able to do that. So that satisfaction of job and hence slowing the burnout rate, that's a very important concept to know, that every job will burn you out in medical capacity. Even if you're working as psychiatrist, or I know you're in psychiatry training, I'm not sure about you starting, or I don't want to discourage you in any way, but any training method will burn you out. It's the process of slowing that burning out till you're able to reach to the peak of your career or plateau. For that, I think Australia, when it comes to the balance of the patient coming into the hospital, the resources that you've got, the teamwork, I don't feel overwhelmed. So even if I'd say that I get paid like $350,000 to $400,000 depending on how much I'm working, it's easy for me. It's not like I'm working very hard to achieve that number. And I feel good about it. When I come back from my work, I think, look, hang on, I've had a good day today. Like I've managed to save a few lives. I managed to get a few thanks and gratitude. So I think that's what's more important than the financial and money value. These are the figures for an emergency doctor. But if you compare other specialties, these figures could go up to $1 million to $2 million as well. I was talking to one of my surgical colleagues who's an orthopedic surgeon. He said, oh, Rizwan, for surgeon, there is no upper limit. You can work as much as you like. I said, hang on, there is an upper limit. You're limited by your own number of hours. So you cannot work more than 24 hours. The point that I'm trying to make is that if your work requires you to earn money by your presence, you will be limited in whatever capacity. Okay, you can charge more in terms of private surgery or private services that you're providing, but you will be limited if the services are dependent on you. But working as a doctor and having some sort of side hustle you can rely on your team to generate same, if not more income.
So basically, there is technically no cap on the salary. It's only limited by the number of hours you have, right? And it seems like you're paid well for the amount of time you spend on it. I think that's a great point. And again, not feeling burned out is a big thing, because I remember my time working as a doctor in India, I just was burned out all the time. Like in India, we didn't have a concept of a weekend. Like I'm not even kidding. On Saturdays, we used to go to work. Like Sunday was the only holiday when you will do like homework or something. And then you'll come back to work. In the US, you have the weekend at least. So I have time to go into these side hustles or make videos or do things of my interest. And exactly like you said, slow down my burnout rate. So on an average, in the US, residents work about 70 to 80 hours and attendings work like 60 hours. The average salary in the US is about $65,000, $66,000 a year for residents. And for attendings, it's close to $350,000. Are you familiar with what the figures are for Australia?
Yeah. So on an average, the intern, which is freshmen out of med school, would be on a salary of 60 to 70,000 Australian dollars per annum. The resident would be between 80 to 110 to up to 120,000 per annum. That is Australian dollars. The attending, there's a registrar then. So registrar are the people who are actually in training. So you can compare them to somewhat like a resident in the USMLE, resident year 1, 2, and 3. So they'll be registrar year 1, 2, 3, and 4. They would be between 120 to up to 140 to $50,000 per annum. Australian dollars. And finally, the consultants. The consultant salary starts at $250,000 in government sector and peaks at about $550,000. But then again, that's your salary in a government sector. If you're doing locum on top of that, which is like a VMO contract, then you can easily double this income. So it's not unusual to see emergency physicians who are working full time earning close to about $750,000 to $850,000, and the surgeons approaching numbers close to about $850 to $950 up to $1 million. So that's all Australian dollars, by the way, and that's all pre-tax. So the salary is pretty good. It's good remunerated. You're only, as I said, limited by your number of hours. And if you can work out a balance between your productivity and slow your burnout rate and work with the hospitals that you feel comfortable, you got good buddies, good relationship, good teams working there, then I think it's pretty good.
Okay. And the average number of working hours per like resident and attending, like on an average, how much do people work?
So average hours, in fact, the maximum number of hours I'd say would be 50 hours, but that you get paid penalty on top. But average hours, which are mandated under the rules and regulations, are 40 hours. So full-time work in Australia is considered 40 hours per week. So for an emergency physician, that's 10-hour shifts. So I'll give you an example. If I'm working 40 hours a week, that's my full-time work, out of which 3 shifts would be my clinical shifts, meaning I'm working on the floor, and 1 shift would be my office shift, which I sit down in my office, do some clinical governance, complaints, and check up the results, do a bit of teaching. So I'm essentially working 12 days in a month clinically, and 4 days are my non-clinical days, which give me a chance to grow. So it's pretty cruisy. It does not include my annual leave. So I got 4 weeks paid annual leave. And then on top of that, I get about 21 days of paid study leave, in which I can travel anywhere in the world on a business class ticket, attend a conference, fully paid for, including the hotel and accommodation. And that budget is about $25,000 per annum. And it just keeps on accumulating as you're working. So it's a very good balance, which has been incentivized, that same concept of slowing your burnout. So you're growing professionally, you don't feel burnout. Like I'm going to Koh Samui, Thailand next week on Monday for a conference where I'm presenting, and the hospital's paying for everything, my airline tickets and my hotel stay and my meals, my taxi and everything.
So thanks for being so honest about the conditions of work in Australia. I want to talk to you about the 3 pathways that students can take internationally to become doctors in Australia. What are the 3 pathways, first of all, and then what are the requirements under the 3 pathways, like one by one?
Okay, so the 3 pathways are standard pathway, then there's competent authority pathway, and last, there's a specialist pathway. So we'll talk about the standard pathway. Standard pathway is once you graduate, which is the main requirement, that is you complete your basic or primary medical qualification, MBBS, and your med school is onward directory of medical school or ECFMG, then you are eligible to sit AMC Part 1. So AMC Part 1 is, we'll go a bit more detail into AMC Part 1. Once you pass that, you're eligible to apply for resident medical officer position if you've done your internship in your own country. If you've not done your internship in your own country, like people from China or Ukraine or Russia who may have not completed that internship component, then they can do internship. Of late, I'm seeing more and more IMGs or international medical graduates getting internship position here in Australia. So this is even new for me. 6 months ago or 12 months ago, I used to say, look, come here in Australia after only doing your internship, because internship positions are not as many. But now people who apply for internship position are getting into intern positions as well. So that's the standard pathway. You do AMC 1, you do an internship if you've not done an internship, or a resident medical office position if you've done an internship back home in your own country. After that, can do AMC clinical, or you can do WBA or workplace-based assessment program to get a full registration. And once you get a full or general registration, you can apply for permanent residency and apply for training program in any specialty. The competent authority pathway is more applicable for people from the US, the UK, the New Zealand, the Ireland, and other country with similar health system, or the people who have taken USMLE 1, 2, and 3 and have worked in the US for at least 2 years, having worked in any job in the UK for at least 12 months and New Zealand, then they come via the competent authority pathway without taking any AMC exam. So that entitles them to come and directly apply for general medical officer position. In fact, when I was coming from the UK, I did do competent authority pathway, but at that time, the competent authority pathway was not fully mature back in 2005, 2006. So I ended up doing AMC as well, just for the heck of it. And for me, having done the PLAB 1 and 2, it was just walk in the park. Like, it is so similar. I was working as a full-time emergency doctor, and I was studying for my AMC MCQ, and it took me like about 4 weeks to just get the gist of it because everything was fresh in my mind. Plus, a lot of AMC MCQ exam is based on clinical knowledge. So because you're working in emergency department, you're seeing those cases every day. It was easy for me to pass and passed easily. And same goes with the clinic. So the content is very similar in terms of PLAB comparability to AMC MCQ and PLAB 1 that is, and PLAB 2 with the AMC clinical exam. So that's the competent authority pathway. Last, we talk about the specialist pathway. So of late, not many people knew that. And I hope that they know that there's a specialist pathway for physicians, for surgeons, dermatologists, gynecologists, radiologists, psychiatrists. If you've done MD in India or MS in India or FCPS in Pakistan or Arab board, you can have your qualification, that is the exam, MD exam, FCPS exam, Arab board exam, plus the training assessed by the specialist colleges here in Australia to be found partial comparable, that look fine, your training and exams are partially compared to what we do here in Australia as a specialist, and then you need to do a top-up training time of say 12 months or 24 months depending on how much you're assessed for. And then you may be made to sit the final exit exam. So you don't have to do any of the AMC or any of the primary or early fellowship exam. You just do the exit exam and get to work as a consultant. It's as simple as that. The good thing about the Royal College of Physicians, Australian College of Physicians, you don't have to even do the exit exam if you've been found partially comparable in general medicine or other specialties, because there's only one exam. So this is called the specialty pathway. Now, a specialty pathway is also valid for GPs, which is another big pot where lots of IMGs are coming and interested in. So if they're working as a general practitioner back in the India, Pakistan, UK, and Middle East, where we get lots of our customers from, they can also apply for specialist comparability exams. So if they've done, there's a list of exam, MRCGP UK, there's a membership exams from South Africa, Sweden, Norway, there's French exams, there's Italian exams, there's a whole list which I don't even remember. There are about 20 exams in there. You can have all those exams, if you've done any of those exams, assessed and come and join the training scheme midway through the training, and then sit the final exit exam of the general practitioner and come and work here independently as a general practitioner.
Okay, yeah, thank you so much for that explanation. I think that makes things very clear. And a lot of questions that I have will be brought on later on as we go into the topics as well. But a few questions that, like I personally had is in the specialist pathway, right? They ask you to have some kind of experience. Like when they say experience, what does that mean? Is that like residency experience, or is that fellowship experience, or is it like you've graduated and you're practicing as an attending? And do you need to be like world class basically to get into specialists, like world known? Or because that's how some websites phrase it. Like, because I've read about this, and some Reddit threads also phrase it that way. Like, you have to be world class, have publications. Is it that hard to do the specialist pathway, or those are the questions?
Okay, so let's take it in stepwise. So, in terms of your question, and specialist pathway, that world class terminology, I think is somewhat of misconstrued. It's not world class. It's actually the highest specialist level qualification in your own country. In Pakistan, for example, where I come from, FCPS or Fellow of College of Physician Surgeons of Pakistan is considered the highest degree of postgraduate qualification. Now, there are some other degrees, like you can do MS and MD in Pakistan, but they're not considered the highest level of postgraduate qualification. Now, same as in India, there might be fellowships, which are more like an experience fellowship of 1 year, or fellowship in critical care, fellowship in emergency medicine, which are in partnership with some other UK colleges. They don't count. The highest qualification, which my understanding is MS, MD, DNB, and MCH. So if postgraduate qualification is listed as the authentic and the highest qualification on your country's charter of medical council, that person would be considered a specialist in your own country. That is the specialist degree you must have. That means you've completed the training program or curriculum on that degree, plus you've sat the exam of that degree to become a specialist in your country. The other component is that when they're doing a specialist comparability, and this is often a very confusing aspect, they're actually comparing your training. It's called specialist comparability, but if I was to phrase it correctly, it is actually your training comparability. So how many years have you spent total in your medical training? If for someone in India who has done MD in general medicine, they would have done year 1, year 2 and year 3. What sort of combination of specialties have you done in that 3 years? Like you may have started off with general medicine and then did a rotational cardiology or respiratory medicine and ICU and gastroenterology, and year 3 were more like you spent more time in general medicine. So cumulatively you may have done 2 years of general medicine and 1 year additional as a part of that 3 year into other rotational specialties. Now if you look and compare that with the Australian system, that's exactly what they do with the general medicine basic medical training. Then they come to the advanced level, and that's what I call all my Indian colleagues that look, spend a year or 2 in SR. So there is a senior resident post in India that after the completing of their MD, they spend like a 1 year or 2 year as a senior resident before being granted like an assistant professor job. And that is so crucial because in to understand that senior resident is compared to that of advanced trainee. So now your training program is looking like you've done 4 years of training. If you've done 2 years of SR year and 3 years of training, it's 5 years. It is exactly now comparable to Australian general medicine training of 5 years. So it's the training assessment of your postgraduate training exam, not the specialist. Now, do you need to have a consultant or attending level experience in India or Pakistan? Not necessarily. You could be a fresh graduate out of your training program after completing an SR year and can apply for a specialist comparability. Now, obviously, this space is highly competitive, meaning there are lots of people who are coming with loads of experience working as a consultant for 3 years, 5+ years. So they do get an edge. So that's my advice is if you worked as a consultant for 2 years, then it just reflects well on the application form. Now, why do I say that? So when you're comparing the specialist application form, there's a section, a specialist post, and then it asks you your inpatient duties, your outpatient duties, your on-call duties, your non-clinical responsibilities and duties. And you can only fill in that section if you worked as a consultant. So if you've not worked as a consultant, that section is essentially empty, which puts you at a certain level of disadvantage. Even if you've done 1 year of good tertiary level, consultant level experience, not like a private dodgy 5-bedded hospital, like a proper consultant experience, it just adds so much value. So in summary, if you've got 3 years of MD training, 1 to 2 years of senior resident training, and 1 year of consultant level experience as an assistant professor, you are gold. There's some other requirements which are not big deal, like CPD activities in terms of educational activities, peer reviews, measuring outcome, but that's more technicality, perhaps for another video. But that's essentially it. And then you have to do an English test to apply for comparability assessment.
Yeah, so I think that made it very clear. And from what I got is, so the requirements of this pathway at the basal level is the highest level of qualification for your country's charter, right? You've achieved that level, and anything on top of that is just icing on the top of the cake, right? Is what you're saying, right? Does it also apply to internal medicine physicians? Because I saw like you talked about like general surgery, OBGYN, like all specialties, or are they just specific specialties they're looking for?
So every specialty, the whole thing which might vary a little bit, because the other thing we have got to understand that all of these specialist comparability programs are governed by Australian Medical Board or APRA, which is responsible for giving registration for doctors. Now, when they mandate something, they have to make same laws for every college, for emergency medicine, for intensive care, for medicine and allied like cardiology or respiratory or gastroenterology, psychiatry. So the rules by and large are exactly the same. However, there are a bit more variability between the colleges. For example, Royal Australian College of Physicians only give top-up time of 1 year or 12 months, which means that if you've been found partially comparable, they will say, okay, fine, now you have to spend 1 year in Australia as a registrar to learn and do some assessment reports so we can see you in action in Australian health system before giving you RACP, which is Fellow of Royal Australian College of Physicians. So that is 1 year requirement as a top-up training. When you talk to the surgical college, they may mandate up to 2 years of top-up training time. When you talk to OB&G, they may even go up to months. Now, recently I've come across dermatology college and they may give you up to 2 years to 3 years of top-up time because their training structure is very different to that of an Indian trained doctor. Recently, there was a doctor from India who contacted me only yesterday, who got partial comparability outcome from the College of Dermatology with a top-up time of 2 years. That means that they've recognized his Indian dermatology training of MD and said, fine, we've recognized your general medicine time and dermatology time in terms of how you've explained it, but we think that you need further 2 years here in Australia in dermatology, so start applying for jobs, which is another crucial bit which we need to talk about. What are the jobs? Like, how do you come in, apply for specialist jobs?
Okay, now that we have touched bases on like the different pathways, there's the standard pathway, which requires AMC exams. There is competent authority pathway, and then there is specialist pathway, which like you can bypass the AMC exams using either your degrees in the US or other countries like UK, or your advanced degrees to bypass these exams. So talk to me about the residency training, fellowship structure, and how is the job market like? How does it look like as you progress through training in Australia?
So if I was to give a heading to this section, I'll give a heading flexibility. So you can start your job here in Australia right from an intern, that is right after the med school. You can start as a resident medical officer, year 1, year 2. You can start as a registrar, and you can even start as a senior level consultant. So let's talk about intern. As we've highlighted and touched base before, that if you've completed your AMC 1 after, you can immediately apply for an internship jobs, which are now becoming more and more available. So they are not getting as many overseas medical students, which used to come previously. So that's why there are more internship jobs available. Now, resident medical officer jobs are given on yearly contracts. They are called RMO rotation. So they are advertised every year between the months of May, June, July, and August between different states. And you join the job from January clinical year to the end up to December. So that's for 1 year. And they rotate you from medicine, emergency medicine, surgery, pediatrics, obs and gynae, psychiatry, all of those kind of specialties. 3 months each in various specialties. You can do that for year 1, year 2, and sometimes even year 3, depending on where you want to specialize. And by that time, people who are in WPA program, which is a bypass to AMC 2 or clinical exam, that if you're working in a hospital which provides WBA or workplace-based assessment, you don't have to do an AMC clinical exam, compensate for the AMC clinical and give you a full registration by the end of the second year working as an RMO, meaning you can apply for permanent residency. So that might be a perfectly time when you get permanent residency to apply for a specialist training jobs from year 3 onwards, which is specialist training in medicine, specialist training in surgery, specialist training in emergency medicine, intensive care, psychiatry. You can apply year 3 onwards. And it's an open competitive process. Obviously, some of the specialties are more competitive than others. But if you spent good, as in you've spent with dedication, hard work, good references, done up publications and audits here in Australia, you don't have to do any of these things back home in India or in Pakistan. Here in Australia, then you can make it happen for you. There is a set criteria for all of the colleges that you need to have publication, you need to have international level or national level presentation, you need to be teaching the medical students, you need to have done part 1 exams, and then you can apply for surgical training. You can apply for emergency medicine, pretty cruisy, ICU is pretty cruisy. There are a lot of opportunities which are coming in pediatrics even, so that's very cruisy. Psychiatry is very easy to get into as long as you've got aptitude. In fact, you don't even have to pull in 3 years. In fact, you don't even have to have a permanent residency for psychiatry, because they can say, okay, fine, your permanent residency is in the works. We are sure that you will get it down the line. So why don't you just apply for the program subject to your permanent residency availability next for 4 to 6 months, and you can start the training, because they are looking for doctors. Does it make sense?
Yeah. I also wanted to point out the basic structure of the training in Australia is very similar to the UK from my observation. Correct me if I'm wrong. The training 1 and 2, which is like internship in India and other countries, is similar to being an intern or the first few years of being an RMO. And then after you've done your foundational training in UK terms, you enter core training, which is specialist training or residency training. In Australia, we call this registrarship, right? And then you go to specialist training, which is the UK term for fellowship, and in other countries as well. And in Australia, I think that means fellowship. So what's the duration? Let's say somebody wants to do internal medicine, which is the most commonly vouched for, at least here in the US. How would that look like?
So internal medicine, you would have done internship back home in your own country, or you'll do an internship here in Australia. Then you'll spend at least 1 year as a resident, which would be, as I said, rotational year, combination of specialties, medicine, surgery, pediatrics, obs and gynae. It's just like a general year. Then you can go into or apply for BPT, or basic physician's training. Basic physician's training is for 24 months or 2 years, and you work as a basic physician's trainee registrar in internal medicine, but it would be a combination of specialty. You will be working in geriatrics, general medicine, cardiology, gastroenterology. So all of those specialties you'll be working in. And during those 2 years, Manik, you have to pass an exam which is called Basic Physician's Training Exam, which is the only exam that you have to do to become a qualified medical specialist in any specialties. There's no exit exam in cardiology or anything like that. So once you've passed that exam, that makes you eligible to apply for advanced training in, say, general medicine, which would be another 3 to 4 years, cardiology, respiratory medicine, medical oncology, hematology. So overall, we're looking at 2 years of BPT, or basic physician's training, 4 years of advanced training. So it's about 6 years of total length of training on top of 1 year of RMO and 1 year of internship. So you're talking about 8 years total after the med school to be able to become a consultant.
Okay, consultant, and you're including like fellowship. So 8 years is okay. And by the way, you are getting paid really handsomely.
Yeah. We get a lot of questions, and we were talking about that just before we started the session, is that people often ask me, do you have to pay any fee to be in the residency training program? So there is no fee. You get paid as a doctor right from internship all the way to till you become a consultant. Now, you have to join a college. There's an annual fee for the college, for different colleges, which is like a membership fee. The college is supervising your training, but it's not a fee that you'd pay in hundreds and thousands of dollars. It might be maximum fee of $1,000 per year, which you pay to the college so that you can assign a supervisor and the college keeps track. And when you're about to submit your online assessment, in-training assessment, plus when you're eligible to sit the exam. So that's more sort of a regulation fee with your respective college of emergency medicine, surgery, psychiatry, college of physicians. So there's no fee that you have to pay to get onto the training program, or you pay whilst during in the training program. Please, that is, I want to make clear.
Yeah, so many people are surprised that there's no kind of humongous fee that you have to pay. And it's funny because, that's the mindset they're coming from, is that I have to pay to work as a doctor, which is so counterintuitive. And so what's going on in that country, right? But yeah, like even in the US and even in UK, right, you don't have to pay any tuition fees, like similar to Australia. It's a very minimal fee, honestly, compared to, let's say, in India. Even if you get into the top medical colleges, the fees is close to $1,000 or plus in government colleges that you have to pay yearly, right? Despite not having the same salary. So you're getting paid, I think, like close to $1,200 if you're in the top government colleges.
Wow.
Like very top government colleges, you get paid that much. But the fees again is $1,000 versus if you look at Australia, the pay is much higher and the fees is like non-existent for most people, right? Non-substantial.
That's
right. Another question that I had to ask you is, what's the process for becoming a general physician in Australia? Does anything like that exist? Because in the US, there's nothing like a general physician. Like I know it does exist in the UK.
General physician is a term which is adapted into different terminologies in different countries. So it might be called family medicine specialist or family medicine thing in the US. In the UK, it's still called a general practitioner. And same here in Australia, it's called general practitioner. So general practitioner is a GP. But GP are actually considered specialists here in Australia because they have to pass the fellowship of Royal Australian College of General Practitioners. Plus they have to do a training, which is about 2 years of GP training. And once they get to complete that training and pass that exam, they go on a specialist register, same as a surgeon would go, a physician would go, a cardiologist would go, an emergency physician go. So GP are actually specialists of general practice of family medicine. There are a number of different pathways for general practice, and because there's a huge demand, and I think in my experience, more than 2/3 of IMG will go into general practice. The hours of work are very flexible. It has got an entrepreneurial aspect to it. Like you can open up your own general practice center and keep on opening them and then sell them to a big conglomerate and just take up lump sum money and work as a GP. The pathway of entrance into if you talk about the core pathways, that is, if somebody's taken the AMC or coming in through the standard pathway, once they get a full registration in Australia and they're a permanent resident, then can apply for AGPT or Australian General Practice Training, which is a 2-year program. Once you complete that training, you sit the Australian General Practice Fellowship exam, and after passing the exam, you get your FRAC GP degree and you can work independently as a general practitioner. Now, there are some moratorium restrictions. If you're an international medical graduate, you are made to work in certain regional and rural areas for 10 years, but that 10 years starts from your first job in Australia, which accounts for the hospital. So that 10 years is exclusive for your hospital work. So if you spend 3 years already in a hospital industry, then your moratorium is only 7 years to be spent in regions. And after completion of that moratorium, you can come back into the city areas. But most of the GPs are very happy in the regional areas, as I said before. The life is pretty laid back in the regional areas, and you get all the facilities of modern city in regional towns. Then there's another pathway called Fellowship Support Pathway. Now, that's a pathway to actually pay for it. They can actually purchase a seat, which is called Fellowship Support Program, and they can remain in somewhat more regional without going into a very rural location. The fee for that program is about $25,000 to $30,000. But listen to that. That's over 3 years of your entire GP training. Plus, you will be earning as a GP on top of that. So the first year as a GP, you would be earning in those regional locations close to about $120,000, $130,000. And you can talk to your GP supervisor that, can you help me with some of that fee? And they'll be happily to substantiate some of that fee. So even though it might be looking like you're paying $30,000 over 3 years, $10,000 per annum, you are earning 120, 130, sometimes even $200,000 per annum in that practice. So that is called a fellowship support path. There's also other pathways which are coming in, which is called pre-fellowship pathway, in which you can also work in the area where you're living, in the hospitals that you've trained in. And then again, you have to have a general registration and you can go through it. There's something called pesky pathway. So if you are from India and Pakistan and Sri Lanka and you've got a lot of experience as a GP in your own country, you can submit that experience to Royal Australian College of General Practitioners, have that experience reviewed. They may say that, look, fine, your 10 years of experience is worth about 5 years of experience in Australia, and we'll let you work directly as a GP. Meaning that once you get your AMC 1, you no longer have to do AMC 2. You do a thing called pre-employment structured clinical interview for a general practice, and then work as in that general practice. You'd never see a face of the hospital. You just work in a general practice, and you keep on working in a general practice till you become a general practitioner, finally doing the exit exam. So that's called a pesky pathway. It's like an interview, but you can do that as well. There's another pathway called Australian. So there's another college. There are 2 colleges actually in Australia. There's Australian College of Rural and Remote Medicine. And that is actually, if I would have, Manik, another life, I'd probably become a fellow of Australian College of Rural and Remote Medicine. It is a perfect blend of working in a hospital in a rural setting and working as a general practitioner or family medicine specialist. They're very hands-on. They do anesthesia. They do deliver babies in the far flung out regional communities. They're expert in the rural and remote medicine. They work in some of the most beautiful and outback towns. And they're sometimes the only doctors in hundreds and thousands of kilometers sometimes even. And they have to retrieve the patient. The plane has to come into those towns. That is called a fellowship of Australian College of Rural and Remote Medicine. If you do that, you become an expert or pretty much a doctor in that region for that. But you're also recognized to work as a general practitioner. So you've got dual qualification. You can work in rural and remote, and you can also work as a family physician in urban centers. So say, for instance, you've worked in the regional or remote area for 5 years. You say, okay, fine, I need a bit of a break. What can I do? You can come to the city and work as a general practitioner. People who subspecialize in emergency medicine, they do a lot of FECRM pathways. They man these small rural emergency departments where they would treat snake bites and poisonings and trauma even. As I said, they would deliver babies. They will even see mental health patients in those rural communities. There's a lot of mental health issues in outback, in farmers and rural communities. So they would deal with that as well. And sometimes in those very remote communities, they get paid exceptionally well. Like when I say some of these GPs are very price positioned, they can go up to 700 to up to $1 million because that town is virtually GP less. So they are very well incentivized in those positions. So person who has got like a mixed skill and has got like a GP experience in the background, they can think about that pathway as well. We've talked about the standard pathway, we've talked about the fellowship support pathway, pre-fellowship pathway, PESCI pathway, and Australian College of Rural Remote Medicine pathway. Once you get your full registration, you can join the GP training. That is about between 2.5 to 3 years. And once you complete that training, you can apply for the fellowship. After passing the fellowship exam, you can pretty much work independently in a GP, starting off from the regional community and then urban place. Now, urban places are very saturated. People like remaining in the region where they can open up their own medical center, and this is more financially viable for them as well.
Okay, that was so comprehensive. I didn't even know that there were like 5+ pathways to go to the general training pathway.
Oh, one more pathway.
Yes. Oh my. Which one?
That is called PEP pathway. So all those doctors that we are helping right now who have done MRCGP, or all of those 18 exams that I'm telling you from Norway, from the UK, from European countries, they can have those exams and training recognized and come work directly here as a GP. Some of them don't even have to sit any exit exam. So that is, I would say, the 5th pathway. On top of that, all the pathways that we know.
Thank you for that. What is the shortest time it takes to become a consultant? Like, let's say I'm starting maybe going to the general physician training route, right? Within these pathways, what's the shortest amount of time that it would take for me to become a consultant?
Okay, let's talk about the shortest time to become an internal medical specialist, which is like a get-go specialty for people who are going to the US. Say, for instance, you've already completed like 1 year of internship in India, and you've also done 1 year as a resident medical officer in India. If you have, you can come work here as a resident medical officer, and if you pass the AMC clinical, you can get full registration by the end of your 2nd year or 1st year here in Australia. So that would be 1st year RMO. On an average, let's give it a leeway of 2 years. Okay, so you've done 2 years as an RMO in Australia. That is your first 2 years in Australia ever. So 2 years there. Then you do 2 years of BPT or basic physician's training, and then you do 4 years of the advanced training. So that's 8 years for internal medical specialist. Now this could reduce to 7 years. That means that your RMO, instead of doing 2 years, you're only doing for 1 year, and then you're getting straight onto the BPT if you are planning things well. And people are now getting more smart. AMC clinical rate is now improving. So people who do AMC clinical, they actually save themselves 1 year because they don't have to wait for WBA program to get a permanent residency and full registration to be eligible to get onto a training program as a registrar or resident training. So in terms of your question, 7 years would be the minimum time to complete your internal medicine training, cardiology training, hematology training, whatever training you're talking about. And same goes, the emergency medicine training is now even more condensed now. So instead of 5-year training program, it's now a 4-year training program. So same goes for that, you spend 2 years as an RMO and you do 4 years. So that's 6 years now as an emergency medicine specialist. If you talk about GP, man, the GP is very cool. I really like GP. Like you can have done like AMC 1, you do 1 year of RMO job. Say for instance, if you've done AMC clinical, you can apply for full registration and you can go straight into GP training program, which is 3 years. So that's only 4 years. You can become general practitioners. No joke, 4 years. If you talk about psychiatry, which is your specialty, there is no mandatory requirement for you to do year 1 as a RMO, year 2 as an RMO. People who are local graduates go straight from internship into psychiatry training. And the psychiatry program is about 5 years. So they can become a psychiatrist, consultant psychiatrist, or attending psychiatrist back in the US in essentially 6 years from med school all the way to getting their specialist qualification. So there are different years. My advice now is that, look, if you're really thinking seriously about Australia and you want to save your time and put like a speed to your career progression and very focus, do AMC clinical. The pass criteria has been revised now to 9 out of 14 stations being passed. We've had some good results from our previous course as well. Now seeing many people passing in their first attempt. That will really boost your career. Get you into a surgical training program, get you into a psychiatry training program, emergency training program. It'll save you a year to up to 2 years because WBA programs are competitive. So you may be working in a hospital which offers WPA program, but that hospital would already have a waiting list of doctors. So they may say, oh, fine,
Gotcha.
Yes, we will take you in a WPA program, but not this year, from next year. So they will require you to do 1 year of training, which obviously you're getting an Australian experience or whatever it is, but you're not gaining from that. You would have ideally got onto a WBA training program straight away, but you're not doing that. So if you spend that first year in Australia and pass your clinical exam, that is gold.
Okay. Did not know that about the WBA, that there's a wait
Oh, yeah,
list.
very competitive. Competitive meaning that nobody gets a WBA program as their first job. It's almost certainly going to be a wait of 6 to 12 months because the jobs are essentially the same, but they want people to be dedicated to their system before offering that job to them.
Gotcha. And like also talking about, so we'll talk about WBA later as well as we talk about the AMC exams and like the whole blueprint of how they go, when they happen. But before we do that, I had a question. Like in the US, right? Anybody who is more local here, who is a trainee from the US medical school trainee and they come to residency, they're preferred more in almost every specialty than any international medical graduate. That's true for most specialties, right? And they go into better programs and better specialties. Is this the same case in Australia? Honestly, would they prefer their own candidates who are from Australia, who've graduated from there? Or is it an equal level playing field? Does it matter by specialty?
Okay, I'll give you a very non-biased answer. So there are certain specialties which are undersubscribed. General practice is one of them. They've got 3,000-4,000 places every year and they're not able to fill them. So lots of IMG would like to prefer to go into general practice. Same goes for medicine and allied specialty. And when I'm talking allied, it means general medicine, it means geriatric, it means cardiology even. It means with a bit of luck, hematology and oncology even. Respiratory medicine and gastroenterology. My own colleagues from my own classmates from Pakistan are working as gastroenterologists, respiratory physicians. So they're all at level playing field. Radiology is at level playing field, believe it or not. And emergency medicine, undersubscribed. You can easily become an emergency medicine here. Psychiatry is at level playing field. Pediatrics is at level playing field. ICU, there are lots of people coming in from India in intensive care. After doing anesthesia training there, they want to subspecialize in anesthesia. Level playing field again. Is somewhat balanced. You may, with a bit of luck and bit of expertise, may get into gynae as well. Now, let's talk about surgery. So everything which has got to do with the surgery, it's going to be competitive because the numbers are not as many compared to the numbers that they can offer to local graduates. Obviously, the local graduates would take preference, but it's not the preference because they are local born and bred. It's because they've got the right amount in their CV, which accumulate points to get into an advanced training.
Wow.
There are neurosurgical people who were working as an unaccredited registrar for years in neurosurgery, not able to get into the neurosurgical training position because there are like 20 neurosurgical training position for a year throughout Australia, and they have to shift course. They have to go to ICU or emergency medicine or something else. So it is highly competitive just because the people who put in a lot of effort, they would have done 5 or 6 publications. They would have done like teaching as a lecturer in some university or medical university. They would have done like international level some work and electives in their special field. So that all adds up to their CV weightage. They would work in the rural community of Australia as an unaccredited work and exceptionally got a good reference that some of the local orthopedic surgeons speaking for them, that this is my guy. He works very hard. He's very pleasant. So there's a lot of personality which plays into it as well. And I think as IMGs, we have to understand the game, that the game is not only to have a very good credentials on your CV in terms of publication, research, teaching, unaccredited experience in orthopedics or neurosurgery or whatever it is, and then having a personality of good communication, be always there for your boss who can put out a good reference to the college, and then do the interview exceptionally well, Manik. So these are very structured interview which go on for half an hour for a specialist college's entrance thing, and people mess it up, and you only get certain level of goes in those interviews, like 3 or 4 goes, you say, okay, fine, you're out. So maybe it's a sign that you shouldn't be there. So yes, surgical and allied field are competitive just because there's so many people who want to get into those niche specialties like orthopedic, plastic surgery, vascular surgery. Cardiothoracics have not even opened up their numbers. So there are not many cardiothoracic trainees you can find these days. What else is there in terms of, there's other niche, especially head and neck surgery, breast and endocrine surgery. But I've seen IMGs in all these fields. Trust me. There's good level of acceptability in radiology, even though it has been considered very competitive. But I've seen IMGs in radiology, and these are the most of the IMGs who are coming in through specialist pathway, who are already a specialist back home in India, who went to Middle East, worked there for a few years, and now they're coming in through. So even though you might not be able to gain entry as like a young graduate, although I believe the entry into the surgical training program is not because you're a IMG, it's because of the lack of credentials that you're putting in. But you can also have a lateral entry through specialist pathway. Like if you work there as a surgeon or radiologist, a gynecologist, or anesthetist. Anesthesia is another field. There was one RMO that I was working with from Pakistan, and I was doing an emergency medicine job as a registrar. And I said, oh, what do you want to do? And she said to me, oh, I want to become an anesthetist. And I said, oh, it's very competitive. She said, I'll give it a go. And now she's working as a consultant anesthetist. And that's not just one example, there are many examples. So it's about playing the game right. It's about any other field. If I ask you, like, how many people get shortlisted, the proportion of people getting shortlisted for surgical specialty in the US might be more because there are more positions, or in the UK might be relatively more compared to Australia because they're more position. But in Australia, because they're less position, they are more competitive. But then again, if you play the game right in the US, in the UK and Australia, it becomes a level playing field. Plus, you have to remember, you have to have a permanent residency and full registration before you apply for any of the surgical training program, or in fact, any training program for that matter.
Gotcha. Yeah, that brings a lot of clarity, because I keep getting asked this question, and I think it's a big determining factor, because many people are not sure, especially like when you come from India and you join medical school, you're not really sure through med school, like what do you want to take?
Yeah.
And it generally is a decision of your parents or what the society is saying based upon the rank you get in an exam that you're going to get radiology, because every topper takes radiology. Yeah. So a lot of the times when these people come to the US, they're confused. They're like, we don't know what we want to do, right? So they don't know where they want to apply, which is so important, like down the line, because that determines what rotations you're going to do, right? And there's a cycle to this. And if you don't have a goal set, you don't have a focus, you're destroyed, right? And many people go to the UK because it's more forgiving in that way. Like you have foundational year training 1 and 2, where you're doing an internship, right? If you've done an internship, you're going to FY2, and it's more relaxed in that you can explore a lot of things before you get your feet dirty. Yeah. What's the scene like in Australia? Is it similar to the US, where if I want, let's say, radiology, everything from the start has to be planned, radiology rotations, a CV made towards radiology? Or is it like the UK way? Like, how is Australia in that regard?
Short answer, in the UK way. So you join, as I said, in Australia as a RMO, which is a rotational RMO. Which means that you get rotated through general medicine, general surgery, pediatrics, obs and gynae, emergency medicine, ICU. Radiology as such is not a specialty that you get rotated through, but you will get rotated through ICU and pediatrics and other things. So you will have a taste of it. Now, the good thing about, I think, in UK and Australian system is that you don't have to build a lot after the med school on your CV back home in your own country. You can actually start doing things when you're here in Australia or when you're there in the UK. So if, say, for instance, you've done 6 months and you really say pediatrics, then you can start favoring the next year job from pediatric. Oh, I'll take 12 months of pediatric job. I'll do some ONG and pediatric experience on neonatal job. I'll do some sort of neonatal retrieval experience, ambulance experience, that is. So you can become from second year onwards. Say, for instance, you've done we were talking about orthopedic surgery. You've done 1 year as rotational one. Then you go on to start applying for surgical job. You do general surgery and you do orthopedics. In the second year onwards, you can build up your CV by having publications, by having presentations, by having teaching skills, by having the work references for you. So there's a lot of flexibility from that point of view in both the UK and Australian system, rather than making a point as in the US system that look, right after my med school, I need to get into a psychiatry training. That means that everything that I do pretty much from 4th year from med school onwards has to show that I'm preferring psychiatry. I've done some CBT studies. I've done some extra time in psychiatry wards. I've got some glaring references. I've got like at least, I don't know, 20 publications in psychiatry, maybe. I don't know how many you got. And to get onto psychiatry training program, no, none of that, man. At least after, I'm not saying that you don't have to do it. Don't get me wrong. If you want to play it like you're very sure from the very early years that I want to become a neurosurgeon in Australia or orthopedic surgeon in Australia, fine. Play the game. Right from your internship, you start spending more time. You start publishing in neurosurgery. You start doing an additional year back home in your own country before you start resident level job, and then you build it up here with an Australian experience. So you have to live double kind of life, like back home in India or Pakistan, built up the orthopedic portfolio with publications, teaching and presentation, pretty much what you do in second year onwards here in Australia. So it matches, it makes sense. There's nothing in your CV which is telling me that you are invested in that field. So sometimes people put on their CVs or medical interview when I'm there doing an interview practice, oh, by the way, have you got any questions for me? There's always a question at the interview question. Have you got a question for me? And the RMOs often throw this bouncer at the end. Oh, can I do some research experience? There's nothing in your CV which tells me that you've even sniffed anything close to a research or audit or publication. Why would you put your research experience in there? You can ask so many relevant questions. So that goes on. Whatever you're saying in your interview or you want that to be in CD, it should already be there.
Okay, gotcha. Now talking about like the AMC exams, and I really want to know about what's the AMC Part 1 about, AMC Part 2 about, and when can you take them, where can you take them, and what's the process from the start to an end?
So AMC Part 1 you can take after the completion of your MBBS or primary medical qualifications. You cannot take it before that. It is very clear on the AMC website that you have to have your MBBS qualification approved to make an AMC portal, and that approval is through Epic. So once you've got your MBBS or primary medical qualification approved, then you can take AMC Part 1. Now AMC Part 1 is an MCQ CAT exam or computer adaptive test, which has got like about 150 questions, which are taken over 3.5 hours. There's no negative marking, and they are divided into what I call final year subjects. So there is like about 25% of it, I think I was doing 30% of it's medicine, 20% of it's surgery, 25% is pediatrics and OB&G, and then further 25% is mental health and population health. So it's very, if you can see that it's very much based on the foundations of final year clinical subject. All the exam questions are based on that final year assessment and investigation and management side of things. Now, in order to apply for that, if you jump onto the AMC website, you'll see that you have to make an AMC portal, then you have to pay the fee. And in terms of the venue, it is delivered by Pearson VUE. And if you look at, there's a map of the world there, I think there are about 8 or 10 AMC 1 centers in every state in India. There's none in Pakistan, but they're looking into it. There's none in Middle East either, which is a bit sad really, because people from Pakistan go to Middle East. But there are centers in Malaysia, Singapore, Bangkok or Thailand, Turkey, US, UK, quite a few of European countries as well. Once you do the test, the results come out fairly quickly, within 6 weeks. It's pass or fail. They will give you a score obviously, but it does not matter in terms of you getting a job. I would say that you need about 4 months if you are a fresher starting up, at least, to up to 6 months if you are taking it slowly to prepare for AMC. Now, AMC Clinical, on the other hand, is completely practical. Now, AMC Clinical right now is done online, so over Zoom, as we were talking right now. And the reason it's like they're gone online is because lots of people who want to sit AMC Clinical exam, I think the AMC Clinical Exam Center is going through some sort of refurbishment. It's got 14 stations and you have to pass 9 out of those 14 stations. Each station is like 10 minutes, which 2 minutes is what we call a reading time, in which you read a theme that, look, there's a patient who's come in with chest pain, for instance, and he's got some shortness of breath, and this is a blood pressure which is a bit hypertensive and he's tachycardic. You're meant to take a history and look at the ECG and make a plan. So history, you just assessing him from the cardiac risk point of view. ECG might show atrial fibrillation or something like that, or acute myocardial infarction. And then you make a management plan based on where you are. So if you're working as a GP, then you make a management plan like you're having an infarct and you need to go to the hospital, and I'll give you some aspirin and analgesia and make sure that your family's aware. But at the same time, if you're in a hospital, then you have to make immediately aware, cath lab, open up, make your senior aware, give him initially treatment, Clexane, heparin, whatever it is, and then you get them across to. So it's a lot communication built, and the preparation time for, I think, AMC Clinical is again 4 months, but then those 4 months are completely different to the 4 months in AMC CAT exam, because these 4 months are all about speaking. So it should be very reflex and cerebral when you're preparing for this exam. There's opening statement that should be completed within 3 minutes, because the exam question or task, what they're called, like take history, examine the patient, they're now timed. So they will say you only have 3 minutes to take history, then move on to 2 minutes to ask about the clinical examination, and then you've got 3 minutes to do the management side of things. So management does include investigation and acute management and then long-term management in terms of disposition, whether you're discharging the patient or admitting the patient. So there's a lot which is going on, and if you're not organized in your mind how to say those words in terms of correct terminologies and how you work in Australia, it may not work. And previously it was met with horrendous pass rates. I'll be honest with you, like pass rate as low as 30% at certain dates. But they've looked into these numbers and they said, look, we need to be a bit more comparable to the exams, especially PLAB 2. They have said that, look, we're going to reduce the passing number to 9 to 14. We're talking hundreds of people who used to fail at 9th, and they used to get so many repeals and appeals in that sector. They said, okay, fine, we're going to make a decision. We're going to drop it down to 9. So anybody who's passed 9th station will be passed. So that's improving. Plus, we've got to understand, like, the people who are coming into Australia are not very prepared. They're not switched on as with the USMLE people are switched on right from year 1 even in their med school, or year 2, I'd say more practically. Or PLAB, when they're invested, oh, my mamu lives in PLAB, my chacha lives in UK, I need to go and work in this, all that kind of thing. They're not switched on. So when they come into the new environment, they're mostly the wives and the doctors who have just come here for some reason. And then they think, oh, by the way, I was a doctor. Can I become a doctor? That is mentality. So if I'm sure if the USMLE start coming to Australia, people, honestly, they will destroy the pass rate to take it up to 80%. Trust me, if you give me a sample size of 500 people who take USMLE in terms of step 1, step 2, step 3, and they prepare for AMC, they will completely smash it. Even PLAB, as I said, when I took PLAB and AMC, I did not have to put any effort.
Yeah, that's wow. I know about this negative skew, and I've talked about this in a previous video about how I heard it from you watching you as well, that a lot of this is because of old graduates basically who are here and they end up giving AMC.
Gaps, like clinical gaps of 3 plus 4 plus years.
It's not a popular route, and that's why you end up seeing these pass rates. And if you're a relatively fresher graduate, like remember that there is a negative skew, and this doesn't necessarily apply to you, right? I think that's very important to know as well. And then the workplace-based assessment is another way, if you can have it, to bypass it. What's easier to deal with, WBA or AMC Part 2?
Definitely, I would say WBA, because there's no exam. There's some in-training assessments. You can pretty much, if you got good communication skills, which most people have, it's in much easier way. The only issue with WBA, it takes time to get onto a WBA program. AMC clinical, if you got good communication skills, if you're willing to invest 4 months of your time, prepare for it, it will just achieve so much for you. I do see a certain quality. I've got a quality bias, like the people who I work with who have passed the AMC clinical, they're just so much polished when you work with them on the floor. If you look at their joining the training program, they're the people who would certainly be going towards the specialist route. So they will be becoming internal medical, cardiologist, even surgical specialty. They're much more driven. Yeah, it does not mean, I don't mean to discourage that people who don't do AMC clinical and do WBA cannot get into the special training. Obviously you can, but I'm just thinking that, look, once you've done the AMC clinical, rest of the other fellowship exams, which are pretty much based on the AMC clinical structure, it puts you in the right mindset. So when you're faced with a fellowship exam down the line, like 2 years, 3 years down the line, you're not surprised with the element, I can do that.
Okay. Regarding, because with step 1 and step 2, if you fail, you have an attempt that goes on your kind of CV when you apply for the match, and that prevents a lot of people from matching. It's a very big disadvantage. Is there anything like this with AMC 1 and 2?
You can do AMC 1 as many times as you like, as long as you can afford it. Plus, there's no expiry of AMC 1. So once you've done the AMC 1, it's valid for pretty much your lifetime.
Oh, man.
So it's good from that point of view. And plus, if you look at it, AMC 1 costs what? $2,900 something, $20, I think. So essentially, by $2,920 plus AMC portal fee of $600 or dollars, say like ballpark figure of $4,000-$5,000. For $4,000-$5,000 Australian dollars, which would be US dollar, I don't know how much, probably about $3,000, something like that, $3,200. You can start applying for jobs in Australia right where you are. So if you're somewhere in India, you do AMC 1 in India, you can start applying for jobs in India. That's why I've seen lots of people who have been given a job right when they're in India. They've never set their foot in Australia, and they've been offered a job directly in India after doing AMC 1 there. So basically, once you do your AMC Part 1, you're eligible for limited registration. AMC 2, you're eligible for provisional registration. And once you've completed 12 months of supervised clinical work in Australia, After limited registration, you don't get provisional or full registration. You have to still complete a WBA or AMC clinical. But after you've done AMC clinical on provisional registration for 12 months, you get full registration or general registration, which is called in here.
Okay. So basically, when you clear AMC part 1, like you said, right, that is more limited is what you're getting out of that, right? And then you move on to like provisional, like after you've been here, and then the full registration,
That's
correct?
right. But it does not disadvantage you in any way. So limited registration does not mean that you will have lack of job options for you. Yes, there would be certain states who would prefer AMC pass to provisional eligible people. They are Western Australia, Tasmania, Darwin, Northern Territory states. They prefer people because they haven't got as many specialists to supervise, perhaps. That's my understanding. So they would prefer. That doesn't mean that they would not hire someone just AMC 1 only. So there are some sort of advantages. As I said, AMC 2 pass just opens up entire Australia for you. But AMC 1 would give you options pretty much in the 3 top states, which is New South Wales, Queensland, Victoria, and South Australia, which is a small state but has got a lot of jobs for IMGs. 90% of the jobs are here.
Talking about AMC 1 and versus, let's say, taking the PLAB route, right? Many people, like, what they do is they take the PLAB route because they think, oh, at least we'll get something in the UK. It's a route that is more taken by most people. It's something that's more like globally accepted. Going the PLAB route, it's more popular. So people compare taking AMC 1 and 2 versus PLAB 1 and 2 and doing 1 year of experience there and then coming to Australia. What do you think is easier or harder comparing these two ways of either taking AMC 1 and 2 and coming, or doing PLAB 1, PLAB 2, plus a 1 year experience in the UK and then coming?
Look, it's somewhat of a very personal decision. There's no professional overtones to it. I just find it confusing. If you are in the UK and then you're thinking about Australia, then you're not invested in the UK system. So I believe that if you're invested in any system, you should give your 100% to get on to for what you came from. If you have gone to the UK to do specialist training in cardiology, you should do that there. You should not think that, oh, I'm only here for 1 year. If I don't get a job, I'll go to Australia. That is an option, but it should not be your prime goal. Your prime goal still should be country, dedication, finish up the job, and then move on as a specialist, whatever you want to do after specialization. But look, I'm a bit biased because I pretty much did the same thing. For me, it was different because when I was in the UK, there were no many options in the UK. I was still able to complete and I wanted to go ahead more in the UK. I was just not getting into emergency medicine training program, which I wanted to do. I didn't want to waste time. So I came in here with an intention that, okay, fine. Look, I'll do 12 months to 24 months here in Australia and I'll go back to the UK. Honest to God, that was my intention. But when I came to Australia, everything like bright sun and people are laid back. And I said, oh man, should have come here before. So statistically, most of the IMGs who've gone to the UK have got a job in the UK. They will stay there in the UK. Very small number of people would come over here. But now there are more people who are in various stages of their training and also after completion of their specialization are coming to Australia, which is a good thing because now you're done with the country. You have completed the fellowship, you've got your CCT, you can come here as a specialist. And in our own emergency department, we've got 4 people from the UK who have completed their specialist training in the UK. All they've got to do is 6 months of supervised work as a registrar. There's 1 from Canada, there's 2 from the US. So it makes a lot more sense that you've not duplicated, because if you do these, you almost certainly will end up with some sort of duplication of RMO years. You'll be spending and wasting more time. It'll take about a year to adjust into the new system, although this is the UK system and Australian system, but still to get to understand how the post-graduation training works here and exams work here, it'll still have a transition period of 12 months. So my personal advice would be, if you are thinking of Australia, the opportunities are good, why don't you apply for Australia? You can get into the training positions in GP, emergency medicine, in general physician, pediatrics, gynecology, radiology. These are the best top specialties right now, and with a bit of an effort, even surgery. So why not invest in a system from get-go? But if you're thinking that you want to go to the UK and just try it out, look, I think it just tells me a lot about your personality that you're not fully invested, and then you want to say, if it doesn't work out, I'll go to Australia. Yeah, you can do that, but it does not really improve things for you. If you're not able to get onto a cardiology training in the UK, Trust me, you'll face the same challenges here. It is not going to be easier to get into a cardiology training here. You'll have to do the BPT exam because none of the membership exams that you've done in the UK will be recognized here. You have to do BPT, you have to do basic physician FRCP exam. So what's the point down? Just wasting your time.
Gotcha. So coming into talking about the total cost of the whole AMC pathway, how much would it cost, like from the start to finish? Let's say we start with the degree verification to the last penny that I'll pay the Australian government or the system to just become a consultant cost.
So I don't have the exact figures in my mind, but I know from recently quoted figures like AMC portfolio would be about $650, but do check up on the website what's the latest file. That's the portal. Then Epic verification would be another a few $100. So that's, let's say, $1,000 for that. Then you do the AMC MCQ fee, which is $2,920. I think I checked this morning, $1,920. That pretty much makes you eligible for a job application. Once you get the job offer, you have to apply for registration, which is about $2,000, something between $1,500 to $2,000. And then you have to apply for a visa, which would be another $1,000 for you. So add it all up, how much is it? $8,000. So let's just set aside, like obviously you have to buy a ticket as well to come to fly to Australia. Let's just put $2,000 on top of that. So $10,000 if you've done AMC 1 only, that's Australian dollars. If you add in an AMC clinical, that price would go up to, like AMC clinical fees right now is about $4,390 something dollars. So that's about, on top of $10,000, it'll be $14,391. Something like that. That is not factoring in if you're doing courses or books. Obviously, that is up cost on top of that. That would be for any place. So I would say just for the core Australian government, as you said, how much you're paying, $10,000 for AMC 1 and $15,000 for AMC clinical is a very realistic figure.
Okay, I think that's not a bad number. Like for the US, it's more like $20,000-$30,000. And then you're not even guaranteed a match, versus if you look at Australia, you're starting to make your first income after $10,000. Like you've done AMC Part 1, you can come here, like work under limited registration as an intern, and you're making money at least.
That $10,000 that you have invested, that is your 2 months income. Okay? And if you've invested 15,000 Australian dollars, that's your 3 months income. So if you look at it that way, then it makes much more sense that, look, it's not a lot of what you're investing compared to what you're investing for USMLE.
Talking about like the study materials, you know, that generally people use for us, like in the US, it's first aid. That's the most commonly followed book. Like in general, what study materials, if somebody is starting with, let's say for AMC Part 1 and AMC 2, does the AMC provide its own resources? But I know there's other courses, and I know you're like the number one person for courses, and like your books are like world famous for AMC. But starting from, if somebody just wants to start with like preparation, what could they use?
So I've got my own set of lists of resources. I've penned them down today, this morning, because some of these books have gotten out of fashion and some of the new books have gotten into fashion. So I would recommend the gold book is AMC Handbook of MCQ. So that we're talking about AMC Part 1 MCQ CAT exam, AMC Handbook of AMC MCQ, Anthology of Medical Condition. That is also by Australian Medical Council. Then there's a GP book called Murta General Practice. Any edition which is 7 edition plus, that is fine. Then Oxford Handbook of Clinical Medicine. And believe it or not, the fifth book I would say Kaplan, USMLE Step 2, that is lecture notes. So that is something that you can also do. So these are the 5 reading resources that we will prepare. I'll say text resources. Then we come to the online resources, and you can go and get pretty much lost over. But the top resources would be Royal Melbourne Hospital or Royal Children's Hospital PEDS guidelines, which are very well laid out. Then up-to-date guidelines in certain select subjects. There's ETG guidelines or therapeutic guidelines. There's MBOS MCQ practice tests. There's a Canada QBank, which is pretty relevant for certain subjects. And finally, there's M+X MCQ practice again. So these would be my top resources to prepare for the AMC MCQ. You can spend a lot of time in there and get lost as to what subject to prepare from which resource. And I think that's why you need a little bit of mentorship and guidance as to what to do. And in our course, what we've done is we've created our own portal, which extracts the best juice out of everything and puts into one, like, same thing that it's on Thinkific platform, and it's got hundreds of chapters, which is just a summary of everything. So you don't have to go and spend in depth and read, say, whole 400, 500 page Murta general practice just to do the MCQs. Plus, we've got our own MCQ test in there. So I think it's more about efficiency, but these are the get-go texts that if you start off, have them as a reference, then it's at the end, it's all about the practice of lots of exam material. So this is for AMC MCQ. Look, AMC clinical, I would say you don't have to study a lot. You just have to practice a lot. That's a common misconception, that when people start reading books, it's more about reading guidelines, and the guidelines in terms of there might be a scenario around PV bleeding in the first trimester. You go and jump on the guideline. It'll give you much better value compared to reading a textbook. So you can have the same books that you've gone through in terms of Murta general practice, in terms of clinical handbook as well, you can do that. But it's more about practice. The people who practice more, they have got a much better chance of passing the exam. Trust me on that. And I've seen that number of years. The people who speak well, they're able to time it well. It just flows naturally.
Okay. Yeah. Like, I think that's great advice. So you've got your own number of courses that, my friends have talked about them with me. They're currently like residents in Australia and they were pretty helpful. If somebody is starting with AMC, like what course of yours would you recommend? Is there a book? Is there a course that somebody could just start and give AMC 1 and for AMC 2? Like what courses would you recommend?
So look, our course right now are the best AMC course. We capped the number at 100 students, but we always spill over to 120. The last course I've got 130. People say, I want to take this course. The amount of resources that we've pulled in with our dedicated team, who's Laura, is just amazing. The detail and the depth we've got, it's all online. We've built a whole online repository of videos, lectures, and then relevant text that you can pretty much read everything, which is a summary of all the books and resources that I've told from that portal. Plus, on top of that, we do live classes like 3 times a week. So you can essentially study those live classes at 3 times a week at evening time. So that actually is taught by the tutors who are all working here in Australia. It just gives you a very good sound basis of knowledge, and somebody's just going through that. AMC clinical course, again, we've got the similar portal, which has got all the videos and notes and the guidelines, plus our tutors all working in Australian hospital, lots of practice session. I jump in my AMC clinical course in the morning session, and I do a lot of communication around the AMC clinical course, which people find very useful. That's based on my experience working in Australian health system for about nearly 16, 17 years. So that's quite good. And we do like trial exams in both AMC MCQ and AMC clinical. So that's pretty useful and handy. So you'll know exactly where you are. That is our resources. So our courses are simply emergencyfocus.net. If you jump onto the website, there's AMC 1 course and there's AMC clinical course. The registration is open for like the next course, which I believe is from September and October, and they can go and register.
Surely, you definitely have the most extensive knowledge base for AMC, as per my knowledge, because I've researched a lot. I know there's other companies, but you're the one who's provided the most value through your YouTube channel. I'll mention all of this below in the links in the description and the comments, guys, so you can check that out. I also wanted to just talk about, I know that you have to do OET. When do you write OET in the AMC?
Very good question, Manik. So OET is not a requirement for AMC MCQ. It is more requirement at the time of registration. So I almost every time advise our doctors to leave it till after you pass the AMC MCQ, because AMC MCQ now you're eligible to get a job, and you don't want to be in a situation where you got a job offer but you have not passed the A and your registration goes into limbo. For specialist pathway, however, in GP pathway, you have to have an OET or PTE passed before you apply for specialist pathway. So the application form actually asks you to put in your OET details, what date have you taken and what score you've got. Same goes for the GP pathway. You don't have to GP pathway as an international specialist coming here working as a GP. You can time that after you've got your comparability assessment outcome, as opposed to the specialist pathway when you have to submit the application form with the report of, you can leave it just like an AMC till you get the comparability outcome and then do them.
Okay. So I think after this, just lastly, talking about visa, let's say I've done AMC part 1 from my country. What's the process like? What visa do you need to come to Australia? Is there a specific way to get it? And then how does the visa progress into a green card or a citizenship?
Okay.
Lastly, just those questions.
So look, a little disclaimer, I'm not a migration expert, but I'll tell you what I did and people are doing right now. So you apply for a job and the hospital sponsors your visa, which is 482 visa, which is given for 2 years. And that is the visa for yourself and all your dependents, which includes your wife and kids, not your parents. You come on that visa, you work for 2 years, and then If you've got a continuity of job in that hospital or another hospital, you get another 2 years. Now, in terms of your question, a permanent residency, it's actually quite straightforward. Permanent residency, as soon as you get your journal registration, which means you've passed your AMC 1, passed your AMC 2, and completed 12 months of supervised clinical work in Australia, you're eligible to apply for full registration. Once you get the full registration, the day you get it, you lodge your independent skilled permanent resident migrant visa. So it could be as soon as 12 months, essentially. But if you're going through WBA route, then obviously you pass your AMC 1, you do the WBA, which may take you about a couple of years. As I said, there's a bit of a wait time, 6 to 12 months to get onto a WBA program. You get your general registration. And then after the general registration, you apply for permanent residency visa. Mind you, for any permanent residency visa, you have to have a valid English test. So if your English test is expired, you may have to retake it. So just to time it that well. And that's why I feel that AMC Clinical gives you an edge, that because if you've done your AMC Clinical related English test just a year prior to that, and then you've got full registration, you can pretty much validate the same result outcome and apply for permanent residency. Once you've been on permanent residence visa for at least 3 years, you can apply for a passport. There's different official ways into it. You have to have a character check, you have to have a health check again, and there's certain things, and then you have to attend a ceremony and that you get passport. So pretty much from get-go, within about 5 years, you can get a passport. Within about 12 to 24 months, 24 months is more realistic figure to get a permanent residency. And as I said, initially you get on 482 visa, which is 2 years for you and yourself. Now, the interesting thing about 482 visa, that if you are coming here on a doctor visa, and if your spouse is a doctor, he or she can work unlimited number of hours in any industry. So they can go to cafe and work in cafeteria, they can go into work as a receptionist. They've got unlimited work rights. Whilst you are only working in hospital, your spouse has got unlimited work rights. If you've got grown-up children who are school going, they can go to school. But if they want to do some part-time work in some McDonald's something, they've got unlimited work rights as well within the Australian law. You have to have a private health insurance, which is about $1,000 for a family of 4, which is working like a Medicare, like an Australian government Medicare scheme to provide you with medical things. So you have to have a medical insurance for that. But once you become a permanent residence, the medical care is free for you. It's a free medical system for all permanent residents.
So it's free. US here, if anything happens, like it's $2,000, $4,000 down the line. Like for dental treatment, I'm paying I think $12,000 for braces and everything. So that's nice to hear. And getting the green card that fast, like for me, it'll be a 14-year process because of the Indian wait line. But I'm coming to Australia after listening to you. We'll see. Thank you so much for coming here. Again, guys, all the links are mentioned below if you want to reach out to Dr. Qureshi. He is an expert in the AMC route. And this was very extensive, and I really thank you for coming in here. If you have any questions, please let us know in the comments, and I'll be happy to answer them. And do share this video with anyone who could benefit